DTA or any other medication, and exposure risk increase in houses before built 1978, folks. Okay, so what we usually do when they give a history, if they say they live in a house that was constructed before 1978, if the kids lives there, we will do a lead test on the kids just to make sure. That's pretty much okay. And then workplace, right? If you see any commercial building, when they rent, they have to have a lead test done. Okay, you cannot. And because of this, the government offers free lead testing. Like you could actually take a sample water from your house or your office, you could send it to them, they will test it and send it back. Okay, so that's lead poisoning, folks. Is everybody clear? All right, there's a little subcategory, what we call sideroblastic anemia. Now, when you see a sideroblastic anemia, there could be a genetic, or people can get it as a sporadic. Okay. Now, the most common for exam, it's going to be B6 deficiency. Okay, B6 deficiency, especially people who take INH medication for TB. Remember, if you have a PPD positive and chest X-ray negative, you have to take minimum 6 months of INH. We prescribe B6 with it, 400 milligram, okay? Because B6 deficiency causes sideroblastic anemia, folks, okay? Just keep it simple like that. They don't ask more than that. That's the idea. And peripheral blood smear shows basophilic stripling, again, the same thing. Treatment, B6. Is everybody clear, folks? That's sideroblastic anemia, not more to worry here. Now, if you go here, folks, let's clean this page up. We literally finish the whole anemia in here, folks, okay? Now, you should be able to write this chart again and should be able to explain each of these diseases, folks, okay? So that's anemia in here. Any question for me in this anemia chart? That's a bulk of hematology, actually, the big chunk is done. Now, what we're gonna go learn, let's go and learn opposite to anemia. But I want to get some easy stuff first. Let's go here, page 436. Let's do some easy stuff. All right, now, when it comes to blood transfusion therapy, folks, right? When people say, I'm getting a blood transfusion, nobody gets the whole blood transfusion, okay? So blood transfusion is a layman word. We just say blood transfusion. People get a specific things. Some people can get packed red blood cell. Some people can get just the platelet, or some people get FFP or PCC. Cryoprecipitate. It has to be specific, folks, okay? That's how we do it. Nobody gets all of them in one bag. Impossible, okay? Now, who needs packed red blood cell? Who has low hemoglobin, right? When they have a low hemoglobin, they cannot bind enough oxygen, because we know 1 gram of hemoglobin bind to 1.3 for oxygen, isn't it, folks? So that's the idea. So who should we give it to? People who lost blood or who has severe anemia. So the criteria is, I believe, when it goes below 7 hemoglobin, that's where we transfuse blood. We transfuse blood, folks, okay? So whenever somebody comes below 7 hemoglobin, we want to give them packed red blood cell. Giving them packed red blood cell is to replace the hemoglobin. Is everybody clear, folks? Okay. Next, platelets. We give platelets to people to increase the platelet, and when they have low platelets, I believe it's below 35,000. When it drops below 35,000, they consider platelet transfusion. But again, don't blindly memorize this. There are a lot of contraindications. Certain disease you cannot give, okay? So to give this to stop significant bleeding, now let's talk about a little bit platelets. Platelets is important for clotting. We talked about this yesterday. One of the diseases that we frequently give platelets, there is an infection we call dengue fever, right? What is another name for dengue fever? It's called hemorrhagic fever, isn't it, folks? Why? People with dengue, one of the most common complications, their platelet drops. Sometimes it can drop to 10,000 all of a sudden. Okay. So when platelet drops, we keep them in the bed in the hospital. We don't even let them get up, folks. Okay. They cannot even go to the bathroom. The reason behind, if they get one little injury, they will bleed like water. Nothing we could do at that point because they have no platelets to slow down the bleeding. So those people, sometimes we have to give platelet transfusion. Is that clear, folks? That's that, okay? Now, that's an example. Now, I want to tell an example where you do not give platelets, even if you have low platelets. ITP, we studied yesterday. When people come with ITP, why we shouldn't give platelets? If you give more platelets, that platelet will bind to more antibodies that's in the blood serum, and more spleen will destroy. Does that make sense, folks? So people with ITP, platelet transfusion is contraindicated. Are we clear, folks? All right. Now that's platelet. Any question for me? All right. Next one, FFP or PCC. Two things, folks, okay? FFP, fresh frozen plasma, and PCC. Now, what are those? These material, they consist a specific factor, 2, 7, 9, 10 CNS. Ooh, that looks like inhibited by warfarin, isn't it, folks? So who gets this when people get overdose of warfarin? Warfarin overdose get this medicated transfusion, folks. Why? If I give warfarin, it's irreversible inhibition. It will take 3 days for the new clotting factors to come. Does that make sense, folks? They will die before that by bleeding. Warfarin is such a danger drug. That's why we have a Coumadin clinic. Every 2 weeks, they have to go check for INR. We measure the INR and make sure. So if somebody has an overdose, we have to give FFP or PCC. They both are same. But I was told in the exam, they give both options. Which one do you pick? PCC has a better efficacy. They work a little better, okay? PCC is a little better. It's like Starbucks. The other one is like Dunkin', okay? Doesn't work really. So that's PCC, folks. Now, that's the FFP and PCC. Then you have cryoprecipitate. They have that 1 millibrand factor and all these things. So you give it to people who has those 1 millibrand deficiency and stuff, kind of low yield. And then you have albumin. Okay. Now you see, you have all these things, but the exam, they just ask question in these things. The 2 lines here, folks. Okay. Before we read, let's talk about blood donation, right? We donate blood. When we donate blood, what happens? You give blood to the blood bank and they give you back mango juice for free. They give you juice, right? Those juice are good. You can't buy it. They get it from somewhere special. All right. So when you donate blood, what do? They take your blood, they do all the testing to make sure there's no infections, nothing, right? I always tell people, if you want to check your blood group, certain diseases, if you go to your doctor, they're going to charge you money to do those blood tests. If you do a blood donation, you get a free report after 2 weeks, okay? So because they check and they send it to you, what group and all these things. After that, they add chemicals. One of the chemicals is citrate. They add citrate. After they add citrate, they freeze the blood. So it's frozen after that, okay? They keep it in the fridge. It's frozen, basically. Now, when somebody needs blood transfusion, they take this blood back and they warm it up. They actually literally warm that blood. And once they warm, they infuse to a person who needs it. Is everybody clear, folks? When they infuse, what's happening? This citrate is also going into the patient's blood because you cannot remove the citrate separately because it's all mixed up. That citrate will enter. So let's say if I am receiving a blood from blood bank, that citrate is going to come into my body. Citrate is a calcium chelator, which means it will bind to all the calcium. It will bind to all the calcium in my blood. I will temporarily become hypocalcemic. So anytime person receives a blood transfusion, we know they're going to feel a little tingling for the next few hours after that. They always tell that, okay? So that's because of hypocalcemia. NBME literally asks, why do they have hypocalcemia after blood transfusion? The answer is citrate, option C on that NBME question. I'm telling you the option too, so don't miss that question when you take it. Okay, so citrate is what causes hypocalcemia. Is everybody clear, folks? All right. Now, also when you store the red blood cell, let's say you give red blood cell, it's stored. The lifespan is 120 days. So there are some cell will rupture, they break while they are storing. So when they rupture, they release potassium. Is that clear, folks? Because potassium is rich intracellular. When they rupture, they come out. So when this person receives the new blood transfusion, they are getting citrate plus potassium. Is that clear, folks? Buy one, get one free. You get the citrate and then you get potassium. Now the potassium will give you hyperkalemia. So whenever blood transfusion happens, we see two things in the patients right after that: hypocalcemia and hyperkalemia. Is everybody clear, folks? That's why when the blood transfusion is done, we keep the patient at least 30 minutes to an hour in the clinic, and then we send them home because we want to make sure this hyperkalemia don't do anything to your heart. Is that clear, folks? We tell the patient to sit there for half an hour to 45 minutes and then go home. They don't listen. They get into the car and they leave right after that. Okay. Now, do we care? No, but they shouldn't leave. Okay. So that's the idea, folks. So that's blood transfusion. Is everybody clear? All right. So now let's go. Where is this? Okay. Let's go to this page, page 441. Now, we're going to talk about some diseases. Myeloproliferative neoplasm. Myeloproliferative, myelo mean bone marrow, okay? Proliferation mean bone marrow has a problem. That's what the key is here. Now, first disease we're going to talk about, polycythemia vera. Polycythemia vera is a primary polycythemia where there's a disorder of increased RBC, usually due to JAK2 mutation, folks, okay? JAK2 mutation may present with intense itching after shower, okay? When people take hot shower, they get itchiness. Why? Because of the basophilic rupture. That's all. This mast cells and basophil is the reason for that. Now, then they also have some erythromyalgia. Now, remember, folks, when people have polycythemia, they have increased red blood cell, okay? That means their blood is a little thicker. It's almost like a gel. The blood is more thicker. So when they travel in the blood vessel, it's going to be hard because they are thick now. Is that clear, folks? Now look at this. They will have a burning pain. They even have hypotension because the blood flow is slow to the brain. They faint. I had a patient with polycythemia vera fell in the bathroom because they fainted. The blood flow was low. And she hit the neck in the bathroom tub. Both vertebrae was fractured. Okay. Oh, some people, that's why, when people fall, the complication is more than what's the initial disease, folks. Okay. So those are important, right? So episodic blood clots and stuff. We call this hyperviscosity. What is hyperviscosity? Your blood is more thicker than usual. That's all it is. The blood is more thicker than usual, folks. Okay. That can cause even thrombosis and stuff. Now, because your bone marrow is producing so much of red blood cell, do you need erythropoietin? You do not need. So that's why decrease erythropoietin. In fact, this is the only disease where you have increased red blood cell but decrease erythropoietin. Okay, in decrease erythropoietin. And we could see that here. The treatment is phlebotomy, hydroxyurea, and then the JAK2 inhibition, folks. Now, before I go further, let's talk about a little bit of that. So when you take a blood, if I want to check the thickness, what we call as hematocrit, we said yesterday, hematocrit is a test that measures the thickness. How does hematocrit is done? So you have a test tube. In the test tube, you have a fluid. With fluid, you have red blood cell. Is that clear, folks? So the hematocrit is measured with a given amount of fluid for the red blood cell. So we are comparing with the amount of fluid and red blood cell. Now, when the hematocrit is high, it tells you blood is thicker, which is polycythemia. When the hematocrit is decreased, then the blood is thin. We call it anemia. Is everybody clear, folks? Okay. Now, actually, if you see, there is a disease, we're going to talk about different type of polycythemia. I'm going to skip and I'm going to go to the next page. You see, there are different type of polycythemia. This is important. The one we just did is polycythemia vera. Is that clear, folks? Polycythemia vera is a true polycythemia. Listen to me careful. This is a difficult topic, okay? Polycythemia vera is a true polycythemia. True polycythemia means you are increasing the red blood cell production, also a little bit increase in fluid, so both increases the thickness. Is that clear, folks? Now, in this chart, I'm going to put numbers. This is number one effect. This is also number one effect. Because of that, your erythropoietin is decreased. Is that clear, folks? So in polycythemia vera, the primary problem is red blood cell mass is increased with the fluid. Is everybody clear, folks? You need to put that number. Otherwise, you won't differentiate with the rest of them. If you have a high red blood cell, there is no need for negative feedback. So that's why erythropoietin is decreased. Are we clear here, folks? Any question in polycythemia vera? No. Okay. Now, let's go for the next one. There's something called relative polycythemia. Now, what is relative polycythemia? It is not a true polycythemia. So what happened, folks? What did we say we do hematocrit? Hematocrit is checking the amount of given fluid versus the red blood cell, isn't it, folks? What happened if I just take out the fluid out, just the fluid? I'm taking the fluid out, but the red blood cell doesn't change, isn't it, folks? So I'm taking the fluid, keeping the red blood cell, still it's going to make it more thicker, isn't it, folks? So that's what we call relative polycythemia. In relative polycythemia, what's happening? I'm losing the plasma volume, but I'm not losing the actual red blood cell. So this happens when you have a dehydration. So when you have a dehydration, what happened? We are losing the fluid, but then not the red blood cell. So it gives you a false polycythemia. This is not a true polycythemia. Is everybody clear, folks? True polycythemia means your body should produce more red blood cell. Are we clear? So we call this as a temporary, right? It's not a real polycythemia. I'm just losing the fluid. When we lose, it looks like the blood is concentrated and thick. Are we clear, folks? All right. So that's happened with the burn and dehydration. What's the treatment for these people? IV fluid. You just give them a fluid, it goes back to normal. Are we clear, folks? So relative polycythemia temporary, again, make sure you write down the notes. It is not a true polycythemia. Okay, it's not a true polycythemia. Are we clear, folks? Anybody don't understand this? Okay, now let's move to the next one. Appropriate absolute. See, the word can confuse. Here what's happening? There is a lung disease that causes hypoxemia, decreased oxygen saturation. When you have a decreased oxygen saturation, what will happen? Erythropoietin stimulated. That's your number 2 effect. When erythropoietin stimulates, it increases red blood cell mass. Simple. 1, 2, 3 order. So everybody clear, folks? That's a true polycythemia in response to hypoxemia. If you see all these diseases that causes hypoxemia. What are the 5 causes of hypoxemia? Come on, let's make a Good Friday. What's the 5 cause? We already have one here. High altitude, hypoventilation, VQ mismatch, diffusion problem. What's the last one that doesn't get better with 100% oxygen? Shunting. Shunting does not get. Okay, very good. So that's appropriate absolute, folks. So the problem with hypoxemia, that's where the problem starts, okay? That's where the problem starts. Is everybody clear, folks? All right. Now, next one. Inappropriate absolute. Inappropriate behavior. People have ectopic production of erythropoietin. That means they are getting erythropoietin from outside, or they have ectopic malignancy. Somehow you are getting erythropoietin. That's your first effect. Is that clear, folks? You could receive from outside, or you could have hepatocellular carcinoma, renal cell carcinoma, pheochromocytoma. All these diseases will give you small cell lung cancer. All of them produces erythropoietin. That will increase red blood cell mass. Is that clear, folks? Now, if I ask you to differentiate appropriate from inappropriate, how would you differentiate? The only difference, appropriate has low oxygen, inappropriate has normal oxygen. Is that clear, folks? That's the only difference. See the word inappropriate behavior, because when you have ectopic, it's an inappropriate behavior. When you have a hypoxia, it's an appropriate behavior to bring oxygen. Is that clear, folks? So that's how you want to remember those three. So that's three. And then yes, there are 4 types of polycythemia, folks. Question?
Blood doping.
What is it?
Blood doping.
What is it? What do you mean?
What is blood doping?
I don't know this is the procedure they do blood doping. Where do you see?
Right there. Athlete misuse, also called blood doping.
Oh, blood doping. Athlete misuse, basically infusing blood. They take red blood cell into your body. Blood transfusion.
I think, don't they also take, they actually like take EPO, don't they, to make their bodies make.
Yes, they do. There's one of these cyclist guy, they remove his gold medal back, isn't it?
Yeah, Lance Armstrong, right? Yeah,
I think so. Yeah. Mm-hmm. So basically, people abuse by 2 things. Either they take erythropoietin, or they take the blood transfusion. They take red blood cell, packed red blood cell. When you give packed red blood cell, they're increasing the hemoglobin, which means the oxygen binding capacity is high. See, that sucks. You cannot take that, but you could go live on a high altitude for 3 months and increase your red blood cell. That's legal. Okay, that's a loophole. All right. So, I mean, that's basically both gives you the same effect. One, you live in a high altitude, one you don't, right? So, yeah. Exactly. So these are different type of polycythemias. Is everybody clear, folks? All right, careful, the numbers are important, okay? So that polycythemia. Now let's go back. So we know how to differentiate all the different type of polycythemias. Now look at the next one, essential thrombocythemia. It's a massive proliferation of platelets. They're producing a lot of platelets, but keep in mind, some of them are working, some of them are not. Okay, so it's dysfunctional. They have bleeding and thrombosis. See, the cells that works, they causes clot. The cells don't work, causes bleeding. Is that clear, folks? So that's a platelet. It's a platelet behavior, right? Blood smear shows increased number of platelet, which may be large or otherwise abnormally found. That also gives erythromyalgia. Now, erythromyalgia is again the thickness of the blood, folks. Okay, that's the idea. Episodic blood. Look at this patient A. Look at the hand. Can you believe that? You know how much painful that should be? That should be very painful. But, I always tell this. Look at this. It's a female. Even with that pain, she didn't forget to do her nails. That's an XX gene. You cannot change that. Okay. With that enlarged hand, she still did her nails. All right. So that's erythromyalgia, folks. All right. So that's essential thrombocythemia. Now, last one, myelofibrosis. Look at the word myelo means bone marrow. Bone marrow become fibrotic. So if the bone marrow fails, who do you think can produce blood cells? Liver and spleen. Is that clear, folks? What do we call that? When the liver and spleen produces the blood cell, there's a terminology. Extramedullary hematopoiesis. Outside the medullary, okay? Atypical megakaryocyte hyperplasia and all these things, more fibroblastic activity, obliteration of the bone marrow. So the bone marrow become complete fibrotic. They have a massive splenomegaly, folks, okay? That's the idea here. That is myelofibrosis. Is everybody clear? All right, so that take care of.
Sorry, doctor. You said the liver and spleen could produce red blood cells alone, or like
all the cells, they produce any cells, all the blood cells, all the bone marrow cells can be produced in the liver and spleen. Now remember, they cannot replace 100%, but they could help a little bit.
Thank you.
Okay. All right, so let's do some questions.
Dr. Roy, so from a symptom point of view, though, thrombocytopenia and thrombocythemia present the same in terms of.
Oh, thrombocytopenia means low platelets, only bleeding. But thrombocythemia means you could also have some clots somewhere, not just bleeding.
Okay, but bleeding isn't distinguishing for those.
No, it's not. But if they say just the bleeding, and you need the other features, just the word of bleeding is not enough to differentiate. All right, give me a second. Let me pose some question. All right. I want the diagnosis first. Okay. All right. 20-year-old man is developed a recurrent episode of jaundice. He was separated from his parents at a young age. That indicates the family history. Okay. The patient resided in several foster homes throughout the childhood, but currently lives alone. Nothing I see here. Physical exam shows valid fluorescence minus splenomegaly. There is no lymphadenopathy or hepatomegaly. Everything else is normal. Decreased hemoglobin. LDH is increased, that doesn't really help. Total bilirubin is high, in that indirect is high. The patient has indirect stuff, something is happening in the blood. Okay. But in the patient red blood cells are incubated in a hypertonic saline solution, the hemoglobin is released. That's the osmotic fragility test positive. Okay. So this patient has secondary spherocytosis. Now, they ask, this patient is a great place for the I know a lot of people are fighting with B and E. Answer is E. Because when they break down indirect bilirubin in the blood, they form pigment and stone. Now, I'll tell you why by autoinfarction of the spleen. This is not a sickle cell to form a clot. Most of the time, the brain sickle cell when you're reading, even though you're confusion careful. Hereditary spherocytosis do not cause any clot. There is no vaso-occlusive disease. Only single cell has, not this one, folks. Okay, that's the idea. Look at the 33% when it just you have to be careful. There is no obstruction in hereditary spherocytosis. Is that clear, folks? Remember, their problem is they're missing an anchoring spectrum. Other than that, they are 100% function, right? All right. The only time you be if I tell you this is a sickle cell. Okay. All right. You guys will go back to that test. So what do you ask me? What's the diagnosis? Look at this question, beautiful question. The person has an evaluated in the ERV, weakness, anxiety, and dark urine. The patient was treated for bacterial infection several days ago. So what they give for bacterial infection? TMS, SMX. That's a sulfur drug. The patient was reacting and this is D6PD. Okay. If you know this is D6PD, where is D6PD? Let's start reading here. Glucose 6-phosphate. What is E? You could talk. Elizabeth, what is it?
Oops, sorry.
No, go ahead. Go ahead. Hexokinase and glucokinase. That comes to glucose 6-phosphate. After glucose 6-phosphate, it becomes fructose 6-phosphate, right? And then we don't talk about the enzyme there. Okay. So now from there, this is your HMT shunt. Does that make sense, folks? So C is the answer here. Okay. So that's your GCC enzyme right here. Okay. Now what is D? Going back.
Glucose 6-phosphate.
Glucose 6-phosphate. Very good. What's the name of the disease that you have issues in that enzyme? What is that?
You know it, but I can't remember.
No, I can't remember. Okay.
I can't remember.
Molgurki. Okay. Now that's that. Where do we go this way? Glucose 6-phosphate to glucose 1-phosphate. Glucose 1-phosphate to glycogen. You store glycogen. Exactly, folks. There's an enzyme, but that's where we go, folks. Okay. All right. So that's this. Diagnosis. Okay, first. What's the diagnosis? Again, G6PD. How? Ciprofloxacin is a fluoroquinolones. It can cause the same thing, folks. Okay, so if you see here, other than that, hemoglobin is low. These don't help. But the answer, erythrocyte enzyme deficiency. Okay, that's a G6PD enzyme that's deficient in this patient, folks. Okay, so that's that. Let's try one more. Give me two options if you have two. Okay, I'll take that. Now, how about I give you a little hint? So let's see what's the disease first. The last line, it tells you what it is. Enzyme assay performed in a circulating blood cell demonstrate low pyruvate kinase activity. That's a pyruvate kinase deficiency. It's right there, right? You don't even have to read it. Now they're asking which of the following is the most likely cause of the patient's splenomegaly. Because why? In that disease, red blood cells are rigid, and when they go to spleen, spleen destroys it, isn't it, folks? Okay, now how do you pick this? These both words are good one. One is a passive splenic congestion, other one is a red pulp hyperplasia. Now I'm going to tell you that the answer is red pulp hyperplasia, okay? Because red blood cells are located in red pulp of the spleen, okay? Now, why not passive splenic congestion? Let's talk about passive splenic congestion. Mean your splenic vein is blocked, all the blood is backing up in the spleen. It's a traffic jam. Is that clear, folks? So when do you pick C as an answer? If somebody has a stomach cancer or blood clot in splenic vein. Is everybody clear, folks? So stomach cancer can compress the splenic vein, or there's something blocking the splenic vein. This is a splenic vein obstruction. Is everybody clear, folks? So I would go to...
Sorry, go ahead.
I would go to pyruvate kinase deficiency on the first state, right next to it, red pulp hyperplasia, and also write passive splenic congestion, arrow, splenic vein obstruction. So you know how to differentiate that. Okay, go ahead, Alyssa.
Would you still have splenomegaly in passive splenic condition? or
Yeah,
no?
anything you back up on the spleen will enlarge.
You're backing up. Oh, okay. Fine.
When the splenic vein is blocked, the splenic artery is still bringing in blood into spleen. So
Yeah, I
you're-
know. I was thinking before the spleen for some reason. I know. Fine.
All right, so that's that. Right, make sure you write both options because these both are good options, folks. Because think about it, in 1 minute, you will jump and click one, okay? So that's very important.
Doctor, do we ignore the reason why, even though it was stated there, I saw that pyruvate kinase deficiency is for newborns, hemolytic anemia, but So we can just ignore that age.
You know, I understand a 10-year-old boy, but they are given a clear picture of low pyruvase kinase. Like, you know, you have one factor versus the other one, right? So so if you ignore, let's say you take the age into a consideration, what's your diagnosis then?
I chose passive splenic congestion because I was like, maybe
Okay,
sickle cell
that's
because
fine.
it's
Now,
that-
okay, let's say, so you say passive splenic congestion, what disease did you have in your mind?
sickle cell.
If it is a sickle cell, it should be splenic infarction, not passive congestion.
Because
Block splenic artery.
black splenic artery is different. Doesn't sickle cell do that too? Obstruct.
Yeah, sickle cell causes splenic artery obstruction, vaso-occlusive disease. So the spleen will die, not a congestion.
What's the difference? One more severe?
No, passive splenic congestion means something is blocked, bloods are accumulating inside the spleen.
Mm-hmm.
Whereas autosplenectomy that happens in the splenic infarction, no blood is even reaching the spleen. Spleen is shrunken and they are dying.
Ah, okay.
Think about a balloon. If you have a tube that gets the water to the balloon, if the tube is blocked, you won't even get the water into the balloon, isn't it? So in sickle cell, there is no splenomegaly, spleen is dead. No, nothing is happening. Okay. This, I don't think I mentioned it, but let's try it. Get the diagnosis at least. So you could see flow cytometry shows absence of CD55. That's a paroxysmal nocturnal hemoglobinuria. We all know. Okay, I should have mentioned it, but always remember when people have PNH, a lot of hemoglobin goes and accumulate in the kidney. We call it hemosiderosis. Okay, write it next to it. Hemoglobin accumulating there, we call it hemosiderosis. Hemosiderosis is a finding in the kidney with PNH, folks. Okay, so that's that. All right, so just write that down next to PNH so you know the terminology. Once you are done, try this one. What's the diagnosis? This is a sickle cell. Did we get that? Because painful vaso-occlusive crisis. Is that clear, folks? So now they're asking, this question is, if I have to make it in one line, what's the mechanism of action of hydroxyurea? Increases fetal hemoglobin synthesis. That's it. Simple, okay? That's the mechanism of action. That's exactly what they're asking here. Clear, folks? All right. So that concludes some question there. Let's go back. Let's go to this page, page 438. Some important high yield diseases. Now in immunology, we remember B lymphocytes become plasma cell in order to produce immunoglobulins, isn't it, folks? We studied that. Now we're going to talk about plasma cell disorders. There's some plasma cell disorders. You cannot come out of the exam without having a question in multiple myeloma. Multiple myeloma is the #1 bone cancer. They don't say it in the bone cancer section, but you should remember, because #1 is multiple myeloma, #2 is osteosarcoma. Is that clear, folks? People think osteosarcoma #1, it is not, it's #2. Multiple myeloma is #1, okay? Now, definition of multiple myeloma, plasma cell neoplasm. Your plasma cell has a cancer that produces excess amount of IgG and IgA. That's very specific. They only produce IgG and IgA, folks, nothing else. Nothing else, just IgG and IgA. In those two, they said more IgG than IgA. Is that clear, folks? That's a multiple myeloma. Now, let's take a look here. In this immunoglobulin, IgG and IgA, right? If you take one immunoglobulin, it has heavy chain and a light chain. Are we clear? These light chain, they enter the kidney. The minute light chain enter the kidney, it gets a special name we call Bence-Jones protein. I'm going to put that. So the minute those IgG and IgA light chain enters the kidney, it gets a special name Bence-Jones protein. Okay. This light chain is also called kappa, lambda, is all name for it, different name for it. Kappa, lambda, Bence-Jones, all of them, folks. Now, the minute it enters the kidney, it's a Bence-Jones protein, which is a toxic to kidney. So it shut down the kidney. So they have renal failure. They have a renal failure. That's why they have renal involvement. You guys see that? You have the renal involvement. If you have a renal involvement, there is no erythropoietin, then you have anemia. Okay, renal involvement, erythropoietin, anemia. Now, this multiple myeloma also increases interleukin-1, rank L. What is rank L? Rank L is released by osteoblast, and it goes and binds to osteoclast and activates to break down the bone. When they break down the bone, we call that breakdown lytic lesion. That lytic lesion will cause hypercalcemia by releasing the calcium. You see, one is connecting the other. Is that clear, folks? So they release a lot of calcium in the blood, so they have hypercalcemia. When do we call it hypercalcemia? More than 10.2, right? 8.4 to 10.2. That's where we call it. Okay. So that's hypercalcemia. So you know the explanation to all of them. Is everybody clear, folks?
I'm sorry, what break the rank L?
What is it?
You said rank L is broken by something?
Rank L goes and binds to rank receptor in osteoclast. Osteoclast activated, so the bone is broken down. So they break down the bone to release the calcium. The only way to get calcium from the bone is by breaking down. When you break down, it gets a special name, lytic lesion.
I'm sorry, what did you say about the anemia in multiple myeloma?
When they have a renal failure, no erythropoietin. Without erythropoietin, let me write this. No erythropoietin. Without erythropoietin, no anemia.
Thanks.
No problem. Is this making sense, folks? Step by step. Okay. Now, talking about the lytic lesion. This is important. Otherwise, you will miss a lot of questions. When it comes to bone lesion, they get two types of lesions. Lytic lesion or sclerotic lesions. I'm giving a filtering information, folks. This takes so long to learn, but I'm giving you a filter, so don't miss it. Lyric lesion mean the bone looks thin on X-ray. It's not dark, it's thin, you could see through it. Sclerotic mean the bone is thick. Okay, the sclerotic mean the bone is thick, like very white on the X-ray. Okay, now why do I say this? There is something called back pain. When a person above 50-year-old comes and tell me, I've been having this low back pain, dull back pain for a few months, that scares me, because two differential diagnoses for that is multiple myeloma or prostate cancer. Multiple myeloma and prostate cancer, both are cancers, and they both give you dull backing pain for 2-3 months. Is that clear, folks? That's how they do it. They ignored the back pain, saying, I pull my muscle, I feel better. Then it doesn't, and they come to the doctor. Both gives you back pain, both have the similar symptoms. The answer is multiple myeloma give you lyric lesion, prostate cancer gives you sclerotic lesions. Okay. If you know that, you almost covered 5 different topics now. Okay. So when you see it, that's because when I read a question with back pain, these are my differential. Then I look at the X-ray, you know the difference. Is that clear, folks? And I'll show you some pictures later when we do. I think they have X-ray in the prostate section and reproductive, but I'll show you, but at least you should know. Thin versus thick bone. Is everybody clear, folks? Now, when the bone is thin, that means breaking down. That means they release calcium. If the bone is thick, they are not releasing calcium. Is everybody clear, folks? Only the lyric lesion will give you hypercalcemia. Thick means they're depositing, they're saving, so they don't give calcium. Is everybody clear, folks? All right. So that's the difference between lyric lesion and sclerotic lesions, folks. Any question for me so far? All right, let's go back. Now you could see here, bone marrow analysis shows more than 10% of the bone marrow is being utilized to produce this plasma cell. Okay, more than 10% is taken just to predominate to produce IgG and IgA. Is everybody clear, folks? Okay. Now, even though they are producing so much of IgG and IgA, they are non-functional. Therefore, your risk of infection. You could get infection, but you cannot help because your immunoglobulin doesn't do anything. Is everybody clear, folks? So from the day one, we are producing a protein, what we call as a non-functional protein. Agree? When we produce a non-functional protein, what we call that? Primary amyloidosis. Remember that? Primary amyloidosis. See, that should make you feel very good with multiple myeloma, folks. Everything makes a perfect sense here. Is that clear, folks? All right. So that's primary amyloidosis, okay? That's because from the day one, we are producing IgG and IgA, never functional. That's what it is. Any questions so far? The last thing, when we produce this immunoglobulin, so much of IgG and IgA, they are in the blood, it become like a glue, sticky. What that sticky does, accumulate red blood cell one next to each other. We call that Rolex formation here, okay? Looks like a stacked poker chips. That's that. That's a very unique feature for multiple myeloma. Is that clear, folks? That is your multiple myeloma. If you know this much, there is no way you will miss a single question. Yeah, so I have given everything here. There was a question they asked, lambda and kappa, that means a light chain. Always remember that, okay? So that's multiple myeloma. Any question for me?
So when a patient comes in with back pain, do you automatically just give them the x-ray? Because a lot of the time it is just back pain, right?
So when you come with the back pain, so 2 things we do. We ask the duration, how long they have it. Number 2, a physical exam. And this kind of back pain usually not reproducible because it's an inside problem, but still at the end of the day, no matter what, we will take an x-ray. Okay. And then, you know, the far part is when you take a history, you would know it's a traumatic or non-traumatic easily. right? The minute you rule out non-traumatic, then in your mind, you're like, okay, it's some of severe disease. So that's exactly how it works. These people will tell the back pain has been there for like 2 months, 3 months. Whereas a trauma patient will say it's been only like 5-6 days. I pull my neck back for doing this and that. Yeah, so that's the idea. But it's good to do an X-ray. It's always good to do an X-ray. Now it's better, but sometimes some doctors say, okay, let's do this muscle relaxant for a week. And if you don't feel better, then come back and we will do an X-ray. Right? But that 1 week can change somebody's life. Right? So it's always good to order an X-ray. Back X-ray is like $100. Okay. Yeah.
What about degenerative joint disease in the back? Like, does that, when on physical exam, will you produce pain on palpation, or do you
It depends.
to do an X-ray for?
If they involve the spinal process, then we will feel the pain. But if they don't involve the spinal process in the back, it won't. It's like, you have to have a fracture, like a vertebral compression fracture. Those things we will feel the pain. Yeah. But it's I think for me, I would order first thing is a back X-ray. Takes 5-10 minutes and you take it and you will know right away. Yeah. All right. So that's multiple myeloma. Now, there is a milder version of multiple myeloma. When I say milder version, precursor before multiple myeloma, we call this MGUS. That's a short form we use. Monoclonal gammopathy of undetermined significance. That's the precursor. What does that mean? People who get MGUS, if you don't treat them, they eventually becomes multiple myeloma. Okay. Now, if you see here, overproduction of any type of immunoglobulin, usually asymptomatic, no CRAB finding. What is this CRAB finding? This is the one. No hypercalcemia, no renal failure, no anemia. Because why? This is not multiple myeloma yet. It is the beginning stage. Is that clear, folks? Now you could see bone marrow shows less than 10%, multiple myeloma more than 10%. So it's like a very beginning precursor. Complication 1 to 2% risk per year of transitioning into multiple myeloma. So in another word, I could tell everybody who has multiple myeloma, they must have had MGUS. But whoever has MGUS, not necessarily they will get into multiple myeloma unless you don't treat. Is that clear, folks? But it's very hard to pick people on this. These are research purpose. They won't even come to the hospital when they are in this stage. Is that clear, folks? See, that's why studying for theory is different and reality is different. We studied all this anemia, right? It looks so easy on the book. Nobody comes right away. I had a patient who came with hemoglobin 4. I actually thought she was a ghost. Why? Below 7, people don't survive. And she came with 4, and we said, stay here. All you need is blood transfusion. First, she asked if he can go to work and come back for blood transfusion. I said, you might not come back if you go, so stay here. But theory cannot explain how did she survive with 4 hemoglobin. But clinical is different. But anyway, monoclonal gammopathy becomes multiple myeloma after symptoms have become severe. Is that clear, folks? Now, Waldenstrom macroglobulinemia. That's another disease, but it's an overproduction of IgM, not IgG or IgA. It's an IgM. It's completely different. So it's IgM. They just have peripheral neuropathy, but no CRAB findings, none of the multiple myeloma symptoms. So you shouldn't confuse with that. They just have hyperviscosity. What is hyperviscosity? Blood is thick. Headache. Why headache? Blood is thick. They cannot travel faster. Blurry vision, same story. Raynaud's phenomena, retinal hemorrhage, all those things, folks. Bone marrow is more than 10%, but that is IgM. Is that clear, folks? That's IgM, and also some thrombosis possibly. Okay, some thrombosis possibly. That's that. Any questions so far? All right, let's do some question in multiple myeloma.
Doctor, this is a silly question, but how is this different from hyper IgM we've talked about before? Like, is that
IgM is basically you don't have a second signal, so there's no class switching, but that IgM is working perfectly fine. There is no any other problem. And
Okay.
remember, and also hyper IgM, you're producing high, but not to like a cancer level. Cancer people produce millions of IgMs. But with the hyper IgM, it's a little bit high, but none of those hyper viscosity syndromes should be there. There's no headache, no blurry vision, none of those.
Thank
That's a good question.
Are these IgM functions? So then are in Waldenstrom macro?
None of the plasma cells are functional.
Okay, thanks.
All right.
Is
So,
Waldenstrom also a type of cancer or anything, or no?
which one?
Waldenstrom macroglobulinemia.
It's a plasma cell cancer. It's a plasma cell cancer, but not multiple myeloma. It has its own name. All right, go for it. Before we start reading, look at this X-ray. Is this look thin or thick? It looks very thin. You could see through it. There's not that much of white color. Do you see that? So that tells you that's a lytic lesion. Is that clear, folks? All right, now it makes it much easier to read this question. Go for it. So when you see a lytic lesion, right? Without reading this, you have to pick a choice. Which one would you pick? Without reading anything. It has to be definitely not D, because D is osteoblast. So that should cause sclerotic lesions, which is thick. Does that make sense, folks? Okay, it's thick. Only osteoclast can break down the bone to release calcium, and that can be thin. Is that clear, folks? So without reading. All right, let's go read here. 66-year-old man come to the office due to several weeks of back and lower extremity pain. The pain feels dull and achy and is worsened by movement, causing him to have difficulty bearing weight and all these things. He has no bladder or bowel dysfunction, extremity weakness or numbness. The patient takes metformin for diabetes, 2 alcoholic beverages daily. Physical shows nothing wrong here, folks, okay? No deformity or anything in the back. We don't see anything in this question except the back pain. Back pain and this X-ray that should suspect lytic lesions. It's a lytic lesion. Of course, I would think of prostate cancer too, but then I saw the X-ray, so that rules out prostate cancer. Is that clear, folks? Then I look at here, hemoglobin and everything, look at the calcium, hypercalcemia. Okay. If I have osteoblast, I shouldn't have hypercalcemia because osteoblast keeps everything in the bone. Okay, so because of that, the answer is E here. Is everybody clear, folks? This is multiple myeloma. Okay, now let's see one of the question I have from a student. Okay, so even though in multiple myeloma, rank L is released from osteoblast, but they go and bind to osteoclast, and osteoclast is the one that activates and releases the calcium, okay? In sclerotic lesion, just osteoblast, no osteoclast involvement. You need osteoclast to increase the calcium level. Clear, folks? Okay.
For high calcium levels in PTH, it would be osteoblast as the answer, not
Say it again.
osteoclast. I remember you talked to us about osteoblast would be the answer for hypercalcemia for PTH, though, correct? Because it triggers osteoblast first.
PTH also osteoclast. Now remember, PTH binds to osteoblast and they release rankle. The rankle binds to osteoclast. And at the end of the day, osteoclast is the one that who does the labor work of breaking down the bone.
I remember you told us that don't get confused and put osteoclast because people used to confuse that for PTH. You told us to choose osteoblast for that.
Now, what I said is PTH binds directly into osteoblast, but I never said osteoblast break down the bone.
Oh, so for if they said which cell for PTH to select, we would select osteoblast or class. That's the
It
answer.
depends on. If a question says where does exactly PTH binds, then osteoblast. Okay, because PTH actually binds to osteoblast and activates the rankle. But if a question asks how does PTH increases the calcium, which cells bring the calcium in the blood, that's still osteoclast because they break it down.
Thank you so much.
Is that clear, folks?
Does
All
the
right.
fact the patient have diabetes or drink have any significance, or is that just extra information for confusing?
Distract. Because diabetes is, and they're taking metformin. We don't even know is it controlled or uncontrolled. They didn't say anything. 2 beverages daily is still considered 14 a week. It's still within normal range. Okay. Now that's the key here, folks. All right. See, that you should be able to answer by looking at this picture. That's a Rolex formation here. Now let's see what you can do. So that's a multiple myeloma question, okay. Another name for light chain is paraproteins, folks, here, okay? So those are your light chain paraprotein. We produce those lambda kappa paraproteins. That's what the problem with multiple myeloma, okay? You could see that. Now, cold agglutination production, B, right? Those we just talked about, IgM, isn't it? The autoimmunohemolytic anemia. That's where the whole agglutination comes. That's IgM. Here we are talking about IgG and IgA, folks. Okay. Let me see which one is this. Okay, go for it. I might have to teach you one second. Let me finish a quick part and then we'll go back to that question.
Dr. Roy, for the rouleau formation, so it's not just the fact that you have all of these, so many red blood cells. It's that you have the light chain accumulation that causes the rouleau.
That's exactly, because remember in multiple myeloma, in fact, we have anemia.
Okay.
So the reason we have all the red blood cell attacked, stacked in one line is because of those light chain. It looks like these people have increased red blood cell. Actually, they have decreased red blood cells.
Okay.
Okay.
Thank you.
Now, you see those light chain we talked about, all the light chain. If you look at this, we call this M spike. You see that, folks? That's what we call the M spike. It gives the appearance of M. In healthy people, we should not see this. Is everybody clear, folks? In healthy people, we should not see that. When you see M spike, those are gamma globulins that produces that. Is that clear, folks? So the gamma globulin is the one that produced the M spike. You see that M spike on a plasma cell disorder. It's not specific to multiple. It could be in other plasma cell disorder also. But what you should know, it's your gamma protein that does the M spike. Is that clear, folks? All right. Now let's go back to that question. See, they're saying protein electrophoresis reveals high peak of gamma globulin. That's M spike, isn't it, folks? M spike is for plasma cell neoplasm. Okay, so that's M spike. All right, folks. So those people who are not satisfied with the osteoclast lesion, one more question. All right. Everybody happy now? All right. So what do you see here, folks? 68-year-old man comes to the office due to persistent back pain for several months. He's a retired vet and hasn't seen doctors in many years. He has smoked a pack of cigarettes daily for 36 years. Smoking is one of the risk factors for prostate cancer. Now you could see cardiac, okay, all this are there. There is a focal tenderness over the 10th rib and L1, L2 vertebral region. Neurological is normal. Radionucleus, even this one doesn't do anything. For me, this is what matters. Radionuclide bone imaging reveals increased activity in multiple area, and they have a sclerotic lesion. Sclerotic means thick, not thin. Exactly, folks. That means if I ask you what cell is activated here, osteoblast. Not osteoclast. Osteoclast breakdown. This is building, right? Osteoblast. So that's your E, folks. Is that clear? That we want to check the patient, the prostate part, folks, nothing else. Is everybody clear? Not multiple myeloma. Okay. Now you could see that. That's the idea. Look at this chart. It tells you what are the diseases that has osteolytic, what are the one osteoblastic, and some of them mix. I wouldn't worry to learn all this. Remember, prostate cancer and multiple myeloma, why? They both gives you back pain. Nothing else gives you back pain. Okay, so that's why we want to remember that. Now, in the drawing we did, we could go ahead and add one more line to make it perfect. Let's go back. In this chart, I would write one more thing. What is that one more thing? I would write this thin line is osteoclast. Here, osteoblast. That's it. So you cannot miss a patient with back pain, folks. Okay.
There's an increase in calcium in sclerotic.
Sclerotic, increase in calcium where? Blood or bone?
Bone.
Yes, not in the blood. Okay. Remember, osteoblast means they are not breaking down. If the bone is thick, more calcium in the bone, less in the blood. Is that clear, folks? If the bone is thin, then you are losing all the calcium in the blood. Is that clear, folks? All right.
That would be hypokalemia, right?
What is it?
That would be hypokalemia in the
Hypokalemia? Are you meaning hypocalcemia?
calcium. Sorry, not
Not necessarily. They might maintain the normal blood calcium level. On top of it, they're accumulating more osteoblast. Not necessarily. So we could only tell this one is hypercalcemia. That's it. Okay. We cannot tell that hypocalcemia. All right. So that's the last part. Is everybody clear here, folks? All right. All right. Go take a break and come back.